You can divide OB clinic visits more or less into four main categories: prenatal checks, contraception advice, annual exams, and vaginitis and STDs. This video will go over vaginitis. The topic is fairly short, very pimpable, and not difficult to learn. We'll cover STDs in another video. There are three main causes of vaginitis: bacterial, which is vaginosis; fungal, which is Candida; and protozoal, which is Trichomonas. So three main causes only, not 300. So you can definitely master this by the end of the video. Now let's apply this clinically. You'll most likely be sitting in the office of your attending and either be handed a patient file or see on your computer that the patient is coming in with a chief complaint of vaginal discharge or pruritus. While it's very tempting just to suggest to your attending that you'd like to meet the patient and just take a swab of the discharge, you actually have to approach these complaints in the same fashion as any other medical complaint: history, physical, and then labs, as there may be more than just a vaginitis brewing. Ask your patient your typical questions like associated symptoms, timing, changes in medications, recent illnesses, recent intercourse, characteristics of the discharge, etc. And then move on to the physical exam. This usually involves a speculum exam, taking a swab specimen from the vaginal walls. The specimen on the swab is smeared onto a microscope slide, which will then help do all the tests required. Now, being the naive third year, I didn't realize that these tests were done by the OBGYN during the span of the visit and not sent to a lab. This is pretty much as homegrown as it gets. The OB steps out of the room and does the following three tests: pH, KOH, and then microscopy. Now, the point of all these tests is to use some detective work to figure out which of the three vaginitis types the patient has. For the pH test, the provider dips a pH paper onto the slide to determine the pH. What you should remember is that the pH swab will differentiate between Candida and the other two, so vaginosis and Trichomonas. Candida is at a normal pH, which is less than 4.5, and the other two are at a higher pH, greater than 4.5. So if you get a test strip which shows a pH of 6, it's either vaginosis or Trichomonas. Less than 4.5, it's likely Candida. However, even if this test indicates that the specimen is likely to be Candida, you still perform the other two tests, the KOH prep and microscopy. So the second test, the KOH prep, will help you determine the difference between vaginosis and Trichomonas or Candida. Vaginosis is the one you probably remember as having the fishy smell after KOH. Sometimes the fishy smell is even evident during the exam. And it's pretty darn fishy when you do smell this. So you can tell your attending with conviction that the patient has vaginosis, and you shouldn't really be trying to tweak your nose to smell the hint of fish. You get it. And I'm sure you already knew that adding KOH and then doing the pH test after will probably mess up your results. Hence, this is the second and not the first test. Finally, you can cover the specimen with a cover slip and take a look under the microscope. By now, you have a pretty good idea of what the specimen is, but microscopy will certainly confirm this. You can see clue cells in vaginosis, motile trichomonads for Trichomonas, and pseudohyphae in Candida. Now, part of the difficulty with this test is that there are variabilities within the specimen that you collect. Clue cells are fairly obvious. They're large epithelial cells with multiple dots, which are the bacteria. But one slide may have few clue cells, or many, depending on how thoroughly you look and how good your specimen is. Trichomonads may or may not be spotted, as they are motile, and if they're swimming outside your field of vision, you probably won't see them. And finally, Candida, you may not always see the pseudohyphae. Last, we reach the treatment. Treatment really is as simple as it gets. You have a 50-50 chance of choosing the right meds. Now what are those for odds? Even better, we're going to treat the fungus with an antifungal. So treat the Candida with topical miconazole or PO fluconazole. The other two get treated with metronidazole, or more commonly known as Flagyl. Now the pearl to know for boards is that trichomonas requires treatment of the other partner, since it's technically an STD, and the patient should be tested for other STDs as well. And one final note, since you will see tables with the same type of information, you'll notice that the tables talk about differences in physical exam findings of each of the 3 vaginitis types. The reason I didn't present them earlier is I didn't feel that they'll change any sort of management. For example, yeast infections are white and itchy, vaginosis has grayish white and fishy discharge, trichomonas has a lot of yellow-green discharge. Nevertheless, you'll always swab these and you'll always do the pH, the KOH, and the microscopy. And finally, while everyone will get treated, these infections need to be taken seriously if the patient's pregnant, as they're associated with preterm labor or premature rupture of membranes. Now for the take-home points. Here's a slide which summarizes this all. So first start with the history of physical exam. Move on to the lab tests. High pH greater than 4.5. Then you do the KOH, which for vaginosis, you'll have the fishy smell, it'll be positive. Trichomonas, you'll see the trichomonads on microscopy, but with a negative KOH. Treat those with metronidazole. Less than 4.5, you're looking at Candida, which will have a negative KOH test, positive pseudo-hyphae on microscopy. Treat this with an antifungal. Now I've written out these on take-home points, as well as just wanted to mention again, for trichomonas, you need to treat both partners and you want to test for other STDs, as this is technically an STD. Thank you.